Assalamu alaikum, everybody. We have just started in last 3 sessions gynae ops anesthesia, and we started with the normal physiological changes and making with considering an obstetric patient for any non-obstetric surgery. Then we did some massive obstetric hemorrhage, and yesterday we did pregnancy-induced hypertension. Okay, so if anyone is not following, it's all the recordings are available on YouTube. So any question related to the previous discussions, if anyone wants to ask, and then we will start with the topic for today. Okay. General rule, if you are dealing any pregnant patient with any medical disease, the general principle is that because already there is altered physiological status of the patient, almost every system being involved, so that change will be making the presence of another coexisting disease even more complicated. So as a general rule, you can say that the effect will not be 1 + 1 = 2. It will be 1 + 1 = 3, like exaggerated response. Okay, so cardiac diseases which already make anesthesia care difficult, if it happens to be a cardiac pregnant patient, then it will become even more challenging. Okay, because of the high cardiac output state and limited cardiac reserve related to the cardiac disease which the patient will be suffering. So what are the usual common diseases which you encounter in a pregnant patient? Anyone wants to ask? Anyone wants to tell? Please, Arsalan. Which cardiac conditions you have seen in an obstetric patient in your practice?
Sir, I think cardiac disease में
Yes,
sir most likely mitral valvular heart disease,
very
rheumatic
good.
heart disease,
Yes,
and SVT and AF.
yes, it will be usually because of because in pregnant patient there is cardiovascular stress. Okay, so that will make some precipitation of the pre-existing condition. So actually, it may be sequelae of the coexisting or pre-existing disease, or there is one condition which is developed during pregnancy. Do you know about it? There is a cardiac condition which develop in pregnant patient, and usually it is a diagnosis of exclusion. Like we will label that disease if there is no other coexisting cardiac disease. That is, anyone knows about it? That is,
it's a peripartum.
Yes, peripartum cardiomyopathy. Okay, so that is a separate entity. So we will just try to target some of the common, like among the valvular heart disease, the most common is mitral stenosis. Okay, it can be a combination of mitral stenosis with like if it is very severe stenosis or it is very prolonged history, then regurgitation will also be coexisting. But usually if we just target on mitral stenosis, for example, to start with, so what are the problems, like what is the sequence of events which occur in a patient with mitral stenosis? Anyone wants to say? Dr. Anila, is it Dr. Anila who just recently joined UK? Are you that Dr. Anila? You know, I want to have some interactive session, otherwise I will keep on speaking and not much of the benefit. Okay. So actually, mitral stenosis, what happens? Rajanan, would you like to tell? Okay, in mitral stenosis, mitral valve is between a left atrium and left ventricle. Okay, so whenever there is obstruction between, if there is a problem in this valve, gradually the movement between left atrium and left ventricle, which is usually passive, and the active part has less component. Okay, so what will happen that gradually, as severity will be increasing, there will be more stress on the heart to transfer the fluid, the blood from left atrium to the left ventricle. Okay, so this will be the prime problem, and then gradually there will be stasis, there will be increase or dilatation of left atrium, and from there on it will be transferring to the lungs. So because the left atrium is connected through the pulmonary veins to the lungs. Okay, so gradually if the disease is prolonged, then will be development of pulmonary hypertension. Okay, and in acute event, if suddenly there is a stress, then patient will be precipitated with pulmonary edema. Okay, so this is the basic. I'm just trying to give you an idea what mitral stenosis, what problem mitral stenosis is creating. Another problem which the patient will have, that because of the stasis of the blood, there will be chances of development of clots, and that clot that might be migrated from left atrium to left ventricle, and it can cause embolic phenomena. Okay, so that will be the problem. So usually, what will be the challenges in a patient with mitral stenosis? Like, what will be the goals? Zishan, would you like to say something?
So anesthetic goals,
Yes.
hemodynamic goals.
Yes.
Slow and tight. We have to keep the heart rate to slow normal.
Okay.
Sinus rhythm, and SVR should be increased.
Will you say SVR should be increased, or SVR should not be let go down?
Yes.
Because if SVR is increased, what will happen? Heart has to pump against pressure. So the problem is that there are limited cardiac reserve. Okay, heart is unable to utilize extra blood, or heart is unable to compensate for any decrease. So you will say that you have to maintain the SVR and don't let it go down. So that is a better answer rather than you say that I want to increase SVR. Okay,
right.
Increase SVR is never good for heart. Would you like to do something like, if your door is not opening, would you like to tighten it so that you have to put more pressure? I don't think so. Am I right? So the concept is that you have to keep the SVR normal, because if there will be sudden, what happens? Why you are worried about giving spinal to a patient with mitral stenosis? What's the issue?
They usually have a fixed cardiac output state.
Okay. What do you mean by fixed cardiac output state? How will you explain it? If you will try to cram the words of the books, okay, this will happen. If someone will ask you any right and left question, you are unable to. What do you mean? You can explain, I think. What do you mean by fixed cardiac output? Yes, please.
Basically, sir, the amount of blood that can be pumped through stenosis, because
no, just a second. If you want to go back, just to make understand what is it, how cardiac output is calculated?
Sir, preload.
Heart rate and stroke volume.
Yes, it is heart rate and stroke volume. Okay. So how,
when there is stenosis,
yes,
there is only a limited amount of blood that can pass through it.
Yes, you can say that heart usually has a lot of compensatory mechanisms. Okay, like normally, for example, if we are sitting and suddenly we stand up, there is a slight pooling of blood in every patient, in everyone. But suddenly what happens, that there is baroreceptor response and heart rate is increased, and sympathetic stimulation occurs, and so it is being compensated. But for that, we need to have a compliant heart. Okay. But if you have some problem in any of the door of the heart, this mechanism will be blocked and the heart will not be able to compensate. Okay, so that response will creating more problem rather than any good. So that is the concept. What do you mean by fixed cardiac output? Okay. So if you understand, you will never forget it. So that's why you have fears when you are giving spinal or epidural to a patient with mitral stenosis, that there will be sudden decrease in SVR. So what will happen? What will be the subsequent effect when SVR is decreased?
Sir, high cardiac output failure.
No. SVR is decreased. So when SVR is decreased, what does it mean? There is pooling. So there will be reduction. There is reduction in preload. Okay. Unfortunately,
pooling.
You know, if you are able to get your connection better, I will be very happy, because we are not able to listen to you. This pain FFH. Okay. I cannot know your name. So anyways, when there is a decrease in SVR, there is a reduction in preload. Okay. So when there is a reduction in preload, this is the mean, like when the heart is receiving less, is not able to pump properly. Okay. So in normal heart, maybe heart will be able to compensate for it. Okay. But in this heart, because the whole of the system is under stress, there is a reduction in flow from atria to ventricle, and heart is more important, dependent on the atrial kick. Okay. So this will be created. So this is one thing that you don't want SVR to be decreased suddenly. And that's the concept of what you started from, Zishan, that you don't want SVR to be decreased rather than it increase. What other thing? What happens if, for example, atrial fibrillation occur in patient with mitral stenosis? Because this is another challenge you will have to face. Why atrial fibrillation occurs in mitral stenosis? It is one of the most common cause of atrial fibrillation in a young patient. One of the most common cause, valvular heart disease, especially mitral stenosis. Why heart going fibrillation, Zishan?
Sir, because the atrium is hypertrophy dilated.
So there are more chances. And if there is atrial fibrillation, the cardiac output will not be able to maintain, because usually the contribution of atrial kick is 15 to 20%, for example, in a normal individual. Okay. But in these patients, if atrial kick is lost, there will be significant decrease in cardiac output. Okay. So that's why you don't want atrial fibrillation. You want to have this one. You want to have sinus rhythm, so that the dependence of heart on atrial click is maintained. Okay. There another problem will be that whenever there is atrial fibrillation, there is more chances of having stasis, more chances of having development of clot. So that is a problem. So that if you are facing a patient with mitral stenosis with atrial fibrillation, you will be suspecting that there will be the atrial clot. That's why if you have a history of more than 24 to 48 hours, you have to do echo to rule out any atrial clot. And if it is there, you have to start the anticoagulation. Okay, I'm just explaining to you the reasons of doing the things which we usually do. Everyone knows about it, but you have to know the reason, so that it will be easier for you to understand. Okay. So another thing is that, what about the fluid management in a patient with mitral stenosis? What will happen? The same reason which we discussed, that heart is going, because even if too much volume is increased, still very fixed volume is going through the door. Okay. So through the stenos door of mitral valve. So even if you give so much blood, what will happen? It will remain in the left atria side, and from there it is pushed back to the lungs, and there is development of pulmonary edema. That's why you have to follow the concept of goal-directed fluid therapy. Okay. And you have to give fluid judiciously. Am I right? It's not called as fluid restriction. You have written the word fluid restriction, but actually it's not matter of fluid restriction. You have to maintain the blood volume. If blood volume is decreased, even then cardiac output will not be able, you will not be able to maintain the cardiac output. Okay? So the concept is that you have to maintain the blood volume. Okay, hypovolemia will not be able to be tolerated in a patient with mitral stenosis. Okay, so that's the concept of it. So the development of pulmonary edema. Then another concept, why pulmonary hypertension occurs. Yes. Similarly, back pressure. Yes, Arsalan?
Yes, sir. Due to continuous pressure build in the right atrium, and they are shifted to the pulmonary vessel.
No, not right
and that,
atrium. Not right atrium. Left atrium.
sorry, sir, left atrium,
Left atrium.
and they are stressing the blood in the pulmonary vasculature, and ultimately they lead pressure in pulmonary vessel, and ultimately they also sir, it's like the left ventricle have to pull more work to move blood into the.
No, we are talking about development of pulmonary hypertension. So it is related to the pressure which is increased in left atria and delivered back to the pulmonary vasculature, which usually is a very peaceful entity and they don't want any fight. But in this condition, because there is a fight going on ahead of them, so that fight is affecting them as well. Okay. So that's the concept of ultimately, if there is too much pulmonary hypertension developed, then it is affecting the right side of heart as well, and it is causing the cor pulmonale sort of picture. Okay, so it is the same thing, that failure of right side of heart because of persistence problem from the left side heart and then delivering back. Okay, so this is the sequelae of events which are occurring in mitral stenosis, and this will also tell you the symptoms, because in mitral stenosis, what are the usual signs and symptoms? Okay, Atik bhai, straight away question to you. What are signs and symptoms in patient with mitral stenosis?
Sir, in mitral stenosis, there will be a shortness of breath, and a sign will be Miller flush on the face, sir. And sir, there will be dyspnea while walking, and dyspnea while syncope, and sir, AF, sir, AF can occur, sir. And sir,
AF is investigation. What about signs? There will be cough with sputum or no?
There will be, sir, cough, maybe sputum there, or maybe there
hemoptysis.
Hemoptysis can be there, sir.
Okay, so this is the concept. Okay, so similarly, when you are facing this patient, you should be keeping all these things in your mind. What else? We talked about atrial fibrillation, we talk about heart failure, we talk about dependence on maintenance of preload, okay, and when presence of sinus rhythm. What else? Usually these patients are on anticoagulants, okay. So this will be also a challenge during the pregnancy, okay. So usual concept is that you have to stop warfarin and convert into heparin. Can warfarin be given in certain circumstances in pregnant patient as well? What are the guidelines for it? Anyone knows about it? Another question is that when you are giving warfarin, how to monitor warfarin therapy?
Through INR, sir.
Okay, so what is the therapeutic level? What are the goal, like how much INR you are targeting in patient with warfarin?
1.5 to 2.
1.5 to 2.
1.5 to 2. I don't think so. It is more.
Sir, it's 2, around 2.
Reconfirm it. I think it is more. I think
for the patients with prosthetic valves, it's almost 3. Okay. And for patients with these kind of patients, like having atrial fibrillation and other stuff, it's 2 to 3.
Yes, actually, if they are asking you, you can tell that both of the things. It was also in my mind that maybe I was thinking about valve replace patient, okay, on who are on lifetime warfarin, okay. So warfarin, can it be given in the pregnancy?
Sir, it is dangerous, but it can be given in extreme cases.
Prosthetic valves, sir. Prosthetic valves can be given.
Yes, there is a guideline actually, because I read that guideline. I will share with you. It is according to the dose. If it is less than 5 milligram, you have to continue. If it is more than 5 milligram, then you have to convert it. There is, I will share with you. I don't recall exactly, but the concept is that, as you told, that even in pregnancy you can give. Okay, in certain circumstances.
It can even given in embryogenesis period, or we will continue after that period.
Of course, all these things are to be considered. Okay, and usually, just a comment about it. Just tell me one thing. Usually, what is the period of organogenesis?
3 to 8 weeks.
31 to 71 days.
How many women knows during that period that they are pregnant? Majority even doesn't know. Okay.
Yes, sir.
So thing is that you are right. The basic concept for is risk versus benefit. Okay. You have to see risk versus benefit. What are the advantages and what are the disadvantages for anything? It is true for anything. If you are answering any question, there is problems there. So you can use this word, that risk versus benefit. Okay. Okay. So these are the basic. I have just explained to you in simple words why mitral stenosis is a problem for anesthetist, and what challenges a patient will have. Okay, if any patient with mitral stenosis you are dealing. Okay. Any question up till now? Okay,
there was a question asked about the pathogenesis of the P mitral. Why the P mitral occurs? What's the reason behind this?
Actually, this is because of left atrial hypertrophy.
Can I answer?
Yes.
Sir, because of the revert backflow in the left atrium, then in the pulmonary system, sir, and in the pulmonary, then in the pulmonary vein, then it becomes engorged in the lungs. Then because the flow is not going to the in the right direction, so the flow is going in a backward direction, sir. There would be strain on right ventricular, and so because of the strain, if it is compensated, then it is okay. If it is not compensated, then it becomes right ventricular hypertrophy and sir right ventricular failure, sir. Pulmonary hypertension and right ventricular both.
What is P pulmonale and what is P mitral?
Yes, sir. He's confusing. Sir is confusing. P mitral with P pulmonale. Basically, sir, what I have learned is the P mitral is because the both atria doesn't contract at simultaneously. So that's why the shape of P waves it gets distorted to the P mitral shape.
It becomes bifid. Okay.
Bifid, sir.
And P pulmonale is what he is telling. It is P pulmonale, yes, sir, because of hyper
pulmonary hypertension. Yes, sir.
Yes. Okay. You understand, Atik bhai?
Okay, sir. Okay.
So this is the reason. And what else you can find? Like if we have started in a different way. We have tried to understand what is it, rather than explaining the time bookish or reproducing only the bookish words. Okay. So you have to know the reason. You have to understand what is it. Then it will be easier for you to swallow, and we will never forget. Till the time I used to read that bloody book which you are used to read all the time, I never understand anything. I never ever understood anything. And when I left it and I understand using my brain through articles, then I came to know that, oh my God, it is so simple and I was not able to understand. Okay. So please try to understand the words rather than ratifying it. It will not give you any long-term benefit even if you know 10 words without knowing any the background knowledge. The examiners are very wise to catch you. Okay. So now if we go back, how to how to assess the severity of mitral stenosis, because that is what is your target. If you have a patient and you want to know how severe is the stenosis, what thing will you focus? Yes, Ishan.
Sir, his symptoms?
Okay, symptoms then.
First of all, symptoms, we'll see the functional class of patient,
Okay.
how she cope up with her daily activities, and what is her response on exertion. Then among investigation, we have to see her ECG for atrial fibrillation. And specifically, we should go for echocardiogram, which would show us the severity of the stenosis.
Okay. So actually, you know, this is a question for everyone, and you have to explain in that for everything, that I will evaluate on the basis of history, examination, and investigation. Okay. I will evaluate on the basis of history, examination, and investigation. Okay. We will evaluate on the basis of history, examination, and investigation. So in the history, as you told about functional class, about any cough, sputum, shortness of breath, functional class, these are the things which you will be asking. And then you will be finding some signs. Sign will be of heart failure, signs will be the same, similar. There is in exam, they can ask you, no, it's not usually for you MCPS oral part, but they can be asked in MCQs as well. What are the ECG findings? Sorry, what are the physical signs in mitral stenosis? I think there is some click, mid soft rumbling. I'm trying to recall in medical school, soft rumbling, mid diastolic murmur, if I'm not wrong, in mitral stenosis, something like that. I don't remember, so you can have a look on it.
Okay. It's same diastolic murmur.
Yes, diastolic, mid diastolic murmur. Anyways, so and then among the investigations, what investigation would you like to do, and reason? Echo to see. What will you see in echo?
To see the area.
Echo to see the valvular area and the pressure gradient across it.
Just finish. What else?
And the motion wall abnormalities. And
no, listen, Atik bhai, you are you try to answer the things which are more important. This is for any echo. Specifically, you told two things. Number one, you told valve size. Number two, you told transvalvular pressure gradient. What else related to valvular heart disease would you say?
Thrombus.
Presence of atrial clot. Okay.
Clot. Okay.
Then there can be agitation as well. So you have
then
to
atrial hypertension and atrial enlargement.
Atrial enlargement. Then pulmonary hypertension. Okay. Wall motion abnormality in any heart you can say. But if they are asking you specifically, try to answer which is more specific. Okay. Then you can go to the other things which you were telling. These are not wrong. Wall motion abnormalities, then hypokinesia, akinesia. Okay. And these are called as segmental wall motion abnormalities. In addition to that, ejection fraction and diastolic dysfunction, which these are the remaining of the things which we see in any echo. What will be the findings in ECG? As we were just talking, there can be atrial fibrillation, there can be P pulmonale, there can be P mitral, any finding can be there. Okay. There can be strain pattern, left heart strain pattern. Okay. There can be, if there is a long standing and there is involvement of ventricle chamber, there can be left ventricular hypertrophy or left ventricular left axis deviation can occur. Okay, so any finding so you have to correlate. What about CBC? What finding you can see in a patient with mitral stenosis?
CBC, there may be increased hematocrit, sir.
Why?
Because of the hypoxemia.
Okay, this is one thing. What else? There are more chances of infections, pulmonary infections. So there can be increase in WBC. Okay. And what other blood works would you like to do?
Sir, serum electrolytes.
Okay, electrolyte because of?
because of the if you are giving digoxin because of digoxin and
Okay.
because of the.
So first of all, another question which I have missed up till now: what are the medication patient might be taking with mitral stenosis?
Anticoagulants,
Anticoagulants, diuretics, and beta blockers, anticoagulants especially, sir.
Okay, fine. So among those, digoxin, diuretics will have effect on electrolytes. Okay, and you have to maintain the therapeutic levels as well. You have to
beta
maintain
blocker
therapeutic levels as well. Beta blocker, of course. Okay, and digoxin, and patient might have pacemaker. Is it possible for the patient having pacemaker?
Yes, it is very much possible, sir.
Okay, it can be possible. It can be possible. So you have to see everything, anything related to according to the severity. Not every patient with mitral stenosis will have pacemaker, but it is a possibility. Patient can have heart blocks. Okay, so this is another reason. Then what about chest X-ray?
Sir, on chest X-ray there will be there may be a double heart border, or sir, maybe it can be calcification can be seen in the mitral valve area, and sir, and see, there will be maybe bat wing appearance, maybe, sir.
Like any signs of congestion.
More prominent vasculature.
Prominent pulmonary edema can be there, sir. Cardiomegaly
you are
can
telling
be
again, Atik bhai, you are missing the simple thing, and you are telling the bookish words which any examiner can catch you. You are giving loose balls to hit you out of the park. Okay, so tell about the simple things first, and then you can show the lateralization or double margin or whatever you are selling. You are right. No, I'm not saying that you are wrong, but any signs of infection.
First of all, left atrial enlargement. Number one, sir.
No, failure. Sign will, if you say just chest X-ray of a patient with mitral stenosis can be normal. If patient is stable. Okay, or it can be have any sign related according to the severity of the disease. Okay, so it can be according to the disease history. There can be chances of infection, there can be chances of failure. So all the signs related to failure or chest infection can be there. And the other things which you are telling, that because of left atrial enlargement, there will be what do you call it?
Sir, it can be curly B lines, or perfusion can be there, and
no. When left atrial enlargement occur, what is that sign? There is straightening. Sorry.
Just he mentioned calcification of the border. I exactly don't know the word, but it is like a calcification something.
Calcification because of left atrial enlargement. What about straightening of the heart border?
There is only straightening of heart border. Calcification is only in the mitral valve area.
Okay, so that is a better answer. And boot shape heart is in it is not in atrial in mitral stenosis. It is
in TOF.
TOF.
It is in GG TOF. Yes, it's in TOF.
Listen. Why you want only the word TOF? Please explain. Usman,
sir,
listen,
sir, yes, sir.
I have a request to everyone who is listening. Please get yourself rid of books. Books are your biggest enemy if you are not understanding them. There is nothing wrong written in the books. Just explain to me how boot shape heart will occur in TOF. Tell me.
Sir, I don't know the exact reason
why you use
but
this
word. Because sir, I've heard written. I've learned somewhere that boot shape heart it occurs mostly in TOF in patients of TOF.
I'm sorry.
I don't know the pathophysiology of
why it's. Remember one thing. Try to understand by reasoning. Okay. Maybe you are right. I'm not saying that you are wrong. Okay. But try to be very simple first, because in the exam, if you use anything, and you are not able to explain, they will fail you. Okay. Usually, if I'm not wrong, it is in regurgitant lesions rather than TOF. TOF is not the first thing. Maybe
it's an aortic regurgitation due to cardiomegaly.
Yes, it is the biggest heart is there in aortic regurgitation. Okay. So maybe I'm not saying that you have told something wrong, but you should be able to explain the reason. If you are not able to explain, rather than don't utter that word. Okay. So this is my message. Okay. So what else? What else? So we discuss echo. We just discuss other. Can there be some problem in the liver?
Sir, excuse me, sir. Sir Zishan.
Yes.
Hello.
Yes.
Sir Zishan, so on the total, on summarize, we can summarize this, especially X-ray. There will be stretching of the left border, and there would be a large left atrium, and there may be cardiomegaly, there may be curly B line because of pulmonary congestion, there may be wall calcification, and there may be pulmonary edema, sir.
Yeah, these are majority of the things except for the left atrial enlargement. This can occur in any diseased heart. Okay. So okay, I'm not telling you specific to mitral stenosis, by the way. I'm telling you any diseased heart, because that you will not forget. But if you will try to memorize very difficult words for very difficult scenarios, maybe you will get something extra, but maybe you can be caught. Okay. So that's my message, that try to be very simple. Try to tell the simple things. Okay.
Okay, sir.
So, so these are the things. Okay. So now we are heading towards conclusion of this mitral stenosis, because if you know the base, then a majority of the things are the same. Okay. So valve size, regurgitant fraction, presence of pulmonary hypertension, heart failure, according to the situation. Okay. Then combined regurgitation or stenosis. There is not much difference in regurgitation because there is back pressure. So there is more left atrial dilatation. Okay. And development of pulmonary edema and pulmonary hypertension similar to mitral stenosis. Okay. And here you don't want heart to be very slow down, because if there is decreased heart rate, there is more time of diastole and there will be more regurgitation. That's why you want to maintain the heart in the high normal side. You don't want bradycardia. And similarly, you don't want increase in SVR. So you have to keep it normal or towards lower, slightly low, like you have to maintain it. You don't let it high, because if there will be more SVR, there will be more regurgitation. This is true for aortic regurgitation. This is true for mitral regurgitation. Okay. Understand?
Okay, sir. Okay. Sir, you were telling us about the liver, sir.
Yes. Is there any involvement of liver in valvular heart disease?
Yes, sir. Due to right heart failure, there will be hepatomegaly.
Yes, there can be some changes in liver. So this is just a back pressure. There will be signs of right heart failure, left heart failure, and then just what is called as congestive heart failure. Okay. So in that, there will be signs of sacral edema and peripheral edema, raised JVP. So everything can occur according to the severity. According to the severity. And severity, you will be picking up from the signs, symptoms. Then you will do some relevant investigations. And then you will be looking at the drug history, how patient is, what sort of medication patient is taking, and how you are handling it. So this is a sequence of events you follow when you are handling this patient. Okay. And majority of the things are common. You will be doing echo, you will be doing X-ray, you will be doing ECG, you will be seeing the serum electrolytes, you will be seeing any presence of pulmonary hypertension, you will be seeing any clot in the heart, you will be having the patient with the anticoagulants. Okay. If the patient valve is replaced, if valve is replaced with the mechanical heart valve, it will be lifelong warfarin. If it is some biological matter, maybe they stop it later on. But this is not your discussion. You have to discuss it with the cardiologist. And there is an anticoagulation team which is supposed to handle the anticoagulants. Okay. So now majority of the things journal things we have understood. In intraoperative period, in addition to the normal monitoring, you will say there should be arterial blood pressure monitoring. There can be need of cardiac output monitoring. So in cardiac output monitoring, you will be seeing the SVR, SVRI, and stroke volume variation, cardiac output. So you will be knowing about the status. And in some condition, you will needing CVP and pulmonary artery catheter. But these are like very specialized and individualized conditions. Otherwise, usually practically speaking, arterial line will be enough. Okay, arterial line will be telling you, and you should have vasopressors and vasodilators according to the situation. You should have that thing. CVP will be indicated if there is need of these medications. Okay, so this is the overall concept you will be handling. Then now the topic, general anesthesia versus regional anesthesia. What are the problems? In which patients would you like to give regional? In which patients would you like to give general anesthesia? In both, now we are heading towards the end of our discussion for related to this topic. So actually you have to tell pros and cons, just like we did yesterday for PIH, GA versus regional. So Zishan, would you like to tell? Like what if you are giving regional and what if you are giving GA?
So for this patient, mitral stenosis patient?
Forget about it. General, what are the general principles? Okay, for example, if you tell mitral stenosis, what would you like to give for cesarean section?
Sir, if it is controlled disease, if the patient is fine and the severity of disease is not much, we can go for regional also. But the general anesthesia will give us more.
What are the problems if you are giving regional?
The problems will be, as we discussed earlier, that hypotension due to decreased SVR.
Zishan, you are missing something. You are missing something. Before giving, what are the problems?
Anticoagulation of the patient.
So this is the first thing to be told. Okay, because these patients are anticoagulant, so you have to optimize or manage accordingly. Okay, so there is chances of nobody can say that it's safe. Nobody can say. So this is the refusal sort of. It's not contraindicated, but it is always a very tricky thing to give regional anesthesia in any patient having any anticoagulants, because you cannot defend. Okay, in the exam you can say this thing that I have any doubt, I will not go for regional. Okay, general anesthesia, just like yesterday we discussed that in regional anesthesia you are able to control the hemodynamics in a better way as compared to regional. Okay.
Yes.
What else?
And in general anesthesia, we will be having more control. We won't be having any problem of anticoagulation on anesthesia side.
Another problem related to regional anesthesia, what is that? One thing you told anticoagulation, other thing you were telling, you have to elaborate that one, that hypotension and relative hypovolemia because of a decrease in SVR can be a detrimental. Okay.
Yes.
So even if you are giving epidural, you can use epidural to, what will be the use of epidural in these patients?
Sir,
general anesthesia, would you like to give some epidural?
Yes, sir, we can. If the anticoagulation status allows us, we would like to put an epidural for postoperative pain.
Yes, you are right, but use even a better word. It will be reducing the stress response in perioperative period.
Yes.
Okay, stress response, and this will be leading to a better hemodynamic control, even if you are combining it with general anesthesia. Okay, and if you are comparing epidural versus spinal, epidural will be a better choice. If you are comparing with local anesthetic and opioids, so you have to give more of opioids. It will be having more. It will be have better effect or more favorable condition as compared to a very concentrated combination of use of local anesthetics. Okay, so you have to use the minimal possible required local anesthetic concentration. What is the minimum which you can use concentration of bupivacaine?
0.125, sir.
No, 0.0625. Okay. 0.0, even half of that. But usually we use 0.1%, which is easier to prepare, and 0.1% we usually use. But even if you will see, even at lower concentration, if you are combining it with opioids, can be used for analgesia, post-op analgesia. Okay. So the role of regional anesthesia, even if you are giving general anesthesia, you can explain to the examiners, or you should be knowing about it. In general anesthesia, you can say that you have to blunt the stressor. What are the challenges during general anesthesia? So there is risk related to the pregnant patient. There are risks related to the stress response. You have to blunt that. Pregnant patient is at risk of aspiration. Pregnant patient is supposed to have a difficult airway. A pregnant patient is already having pharmacological changes. So you have to anticipate accordingly. Okay. So when you are explaining this word, you should be keeping in mind any patient, pregnant patient, you never forget to use this word, that altered physiological, pharmacological, and anatomical consideration in a pregnant patient. Okay. Even if this question is being asked in MCQs, you have to keep this thing in mind. Okay. So you have to be judicious in fluid. No hypovolemia, no hypervolemia. You have to do goal directed fluid therapy. If you are using epidural or spinal, it is better to do preload, so that you are maintaining the blood volume. With you can use colloid in that scenario. Okay. You have to judiciously control the hemoglobin level as well, because you will consider it as a cardiac patient. You don't want any stress. You don't want any decrease in imbalance in myocardial oxygen demand supply ratio. Okay. So these are the things which you have to consider when you are dealing with such patient. Okay. So fluid, analgesia, opioids are very good. Okay. What about NSAIDs? Would you like to give NSAIDs in these patients? Any problem with NSAIDs? Okay. What about dexmedetomidine?
Dexmedetomidine is a good drug, sir.
Yes.
It is cardiac stable.
Cardiac stable? Is it cardiac stable? Atik bhai, you use the word which you cannot defend. Is it cardiac stable thing, dexmedetomidine?
Sir, it is a hemodynamically stable, sir.
No, it causes severe hypotension and severe bradycardia. Okay. It is good for respiratory system. It does not cause respiratory depression. You are using a closed-ended sentence, and the examiner will twist your neck. Dexmedetomidine is not cardiac stable. It causes bradycardia in almost every patient. Okay. So you have to be very cautious in using any medication. Okay. You don't need to use this word, it is cardiac stable. I only have objection in your word cardiac stable. It's not cardiac stable. It's not cardiac stable. You have to use it in a way that you are getting the results. Okay. If the patient is of mitral stenosis and you want to blunt the sympathetic response, you will say, yes, there will be role of Presidex. It will help in blunting the stress response because it will avoid tachycardia. It will decrease the heart rate. So it will be good for a patient with mitral stenosis. Okay. Understand, Atik bhai?
Okay, sir. Okay.
You know, it should be haram for you to use the word best. Nothing is best. Examiner don't want you to glorify something and humiliate something. They just want you to know everything, the pros and cons. You have to be diplomatic. Okay.
Okay. Okay, sir.
What else? What about other modalities? Would you like to use some blocks? You can use like regional blocks according to the coagulopathic condition or anticoagulant. You can use them. Okay. Just like a patient will be needing HDU care. If you want to blunt the stress response, you have to give opioids and you will inform the neonatologist about it. Okay. So I think we have covered almost everything. Valve size, Rattafy thing, then regurgitant pressures or transvalvular pressure gradient. Remember size, we discuss about X-ray finding, we discuss about blood test. Among the blood tests, I was about to tell you and then I forgot, is if there is heart failure, there are some cardiac markers, ANP and BNP or and or any ischemic changes or ischemic, then you can say about the cardiac enzymes. Okay, so this is grossly what you need to know when you are handling a patient with cardiac disease, and there will be optimization of the anticoagulants. You will say that you will be discussing it with the cardiologist, and then in some hospitals there is anticoagulation team which is reviewing the patient and handling according to the outweighing the risk versus benefits. Okay, so GA versus regional we discuss. Monitoring we discuss. There can be need of cardiac output monitor, and this we talked. So this is what you need to know about cardiac disease. And the only thing which is left among the cardiac disease is peripartum cardiomyopathy. So peripartum cardiomyopathy, there are some definitions which you need to do. Actually, is a diagnosis of exclusion. It is a heart failure which occurs in the later half of pregnancy and after 20 weeks without any pre-existing cardiac disease. And there is cardiac failure with severe diminished ejection fraction. There is systolic failure by ventricular failure maybe. Okay, maybe the ejection fraction will be 15 to 20%. There is no pre-existing any cardiac disease or valvular disease before pregnancy. So there are some idiopathic causes related to peripartum cardiomyopathy. It's not, the rest of the things are the same. You have to use the vasodilators. You might need to have anticoagulants. Okay, the same thing which we have already discussed. The separate thing will be what is the criteria of diagnosis of peripartum cardiomyopathy. And another thing is that, would you like to give GA or regional in a patient with peripartum cardiomyopathy? Yes, Atik bhai or Zishan.
GA definitely.
Sir, we should avoid the regional. We will have risk versus benefit, but G is preferred method, sir, as compared to the regional, sir, because of the hemodynamic stability.
Would you like to increase the SVR or decrease SVR, or what would you like to do related to SVR?
Maintain the SVR.
Yes, sir, maintain SVR, sir.
And more important is you should not let it high. Okay, so sympathetic response is very dangerous. Okay, so again, the fluid, you have to maintain the fluids. Patient might need post-operative ICU care. Okay, and it will be high risk patient, and all the things which we have already discussed. Similar.
The hemodynamic goals are almost same like mitral stenosis that we discussed.
Mitral stenosis,
sinus rhythm.
Actually, they are the same. Sinus rhythm, preload after load. Okay.
Yes, sir.
SVR. What else? Avoid hypovolemia. Avoid hypotension. Okay.
Heart rate.
Avoid factors which increase sympathetic stimulation, like my best friends, which I tell everyone: hypoxia, hypercarbia, acidosis, pain, stress response, and then sinus rhythm, preload, afterload, which we have discussed. Okay. Yes. So every base of anesthesia, they can ask you while only asking about cardiac disease in pregnancy. That's why it's so much important. And if any examiner want to, and I tell you something, especially the people who are going for Viva and they have failed, I tell you, an examiner can become biased if you have done a blunder, even one blunder, which is against the basic anesthetic care. I tell you, both examiner will fail you. Even if you have told everything rightly, and then you are cursing the examiner that the examiner failed you. But I tell you that if you are against the basic safety of the patient, no examiner will pass. These numbers 40 or 45 or 52s, it doesn't mean anything. If the word is written fail, it is fail, or word is written pass, you are pass. There is no use of any discussion of any other thing. Okay, please keep this thing in your mind. Don't dig your own grave in the exam. Okay, so this is my message. So I think we have any questions about which we have discussed up till now?
Sir, can we use epidural during PPCM?
Peripartum cardiomyopathy, yes. What will be the advantage? It will decrease the SVR. It will, yes, it will maintain the SVR. So you can use it judiciously.
Yes, sir. Sir, its management will be same like management of a cardiac failure patient.
Cardiac failure. It is cardiac failure.
It
is development of heart failure without any other reason. Okay, like idiopathic.
Okay, sir. Can we do it under local anesthesia, C-section?
Regional?
Local. Just give lignocaine at infiltration.
No. Never use this word. You cannot defend it. What about peritoneum? How will you control the peritoneal stress?
As a surgeon goes down and he will continue infiltration.
No, infiltration. And what? Listen. This is for
infiltrate.
No, infiltrate. How will they block peritoneum? Peritoneum supply is coming for T4. What will they do for it?
Okay, sir. Can we give some sedation along with the local infiltration?
If you are giving sedation in a patient with the mitral stenosis and pregnant patient, if you are giving sedation, you are fail. Never use this word in exam at least. Practically, we could do everything, but if your airway is lost, you are lost.
Okay.
Okay.
Okay, sir.
Okay. So any other question? I forgot to tell about fetal well-being. So you have to monitor the fetal status during the management. If you have this patient for any other surgery, like pregnant patient for appendicectomy, they can ask you. My patient with mitral stenosis in pregnancy for cesarean section. So you should be knowing the basic thing which we have discussed. Okay. So I think that's enough for now. Any question before we finish? The people who have joined late or have not followed this topic from the start, I will suggest you to visit the YouTube channel and see the rest of the discussion which we have done. Okay. So now we have done the bulk of obstetric anesthesia, and we will try to finish in our next sitting the rest of the part, 1 or 2 sittings, inshallah. Okay. Thank you. I try to pull you out of books because books can be your biggest enemy. If you reproduce the words without understanding, I warn all of you, it will create more problem than good. Okay. Okay, everybody. Bye-bye. Thank you. Assalamu alaikum.